in, and I think you can start.
Okay. Yeah, I was unsure. I was waiting for a moment if there was going to be a bit of an introduction, but then maybe let's get started. Indeed. So can everyone hear me loud and clear?
Yes.
Okay, good. Then should I share the slides myself, or are you sharing them from your screen, Irina?
As it is more convenient for you, I can share or you can share,
Okay.
whatever works.
Then I think I will share them myself.
Okay,
So
go
I
ahead.
just sent a request. There we go. All right, so you should see them on the screen right now. Okay, so are we all good?
Yes.
Sure.
Okay, great, amazing. Then let's get started. Good morning, everybody. My name is Kenan de Leeuw. I work as a neuropsychologist at Jellinek in Amsterdam, which is a specialized clinic for addiction, so substance use disorders, but also psychiatric disorders that are common next to addiction. And today, together with my colleague Raoul Koning, who is a prevention expert, we will be discussing substance use, addiction, how addiction arises, how it can be treated, and also how it can be prevented. And we were invited to, share a bit about the way that we work in the Netherlands. And of course, we have also taken into consideration for this webinar here that our circumstances in the Netherlands are very different, right, from the situation currently in Ukraine. So we have really tried as much as possible to make the information that we'll be discussing as relevant and as useful as possible, even when you're working under difficult conditions, as you are, of course, right now. So, as I said, I work as a neuropsychologist. So I used to have a job at a clinic working with people, mostly with traumatic brain injuries, but moved on to the addiction field where this is also quite relevant because addiction is one of the few psychiatric disorders where we really know quite a lot about the brain mechanisms involved. Here's a bit of an overview of the topics we're going to be covering. So it's divided in 3 blocks. So the first one is just a bit of an introduction about common drugs and their effects, how addiction can develop in the brain. Then we'll have a moment for questions and a short break. Then we'll go to the second block, which is more focused on treatment and also psychiatric disorders common in addiction. And then in the final block, my colleague Raoul will take over and talk more about prevention strategies, harm reduction, and then we will have a final Q&A. So as I mentioned, just a brief acknowledgement, right? We might be 2,000 kilometers apart approximately, but of course we are on the same continent. And when we are connected right now, right, digitally, and actually, there is even a group at Jellinek right now, a group treatment for displaced Ukrainian people who also suffer from substance use disorders, which is just to say, like, we might be far apart geographically, but in this way, there is still this global connection. This is a picture of Jellinek. I just wanted to give you a bit of perspective, on our organization. So this, I took this picture a couple of weeks ago. The clinic, some cherry blossom trees in the front, and just very briefly, a little bit of background. Jellinek is one of the oldest treatment centers for addiction in the Netherlands. It dates back all the way to 1909. And it was named after a doctor named Alvin Morton Jellinek, who was an American physician, who was very influential in sort of shifting the perspective on addiction from a moral failing or a weakness, right? Which is for a very long time the way that we looked at addiction and substance use disorders as a sort of personal weakness or a moral weakness. And he was really one of the first to introduce the idea that alcoholism and addiction is a disease, and a disease that can be treated, and a disease that can also be studied scientifically. And that is one of the reasons that the clinic was named after him. And that is still to this day the perspective that we take on addiction, that it is a disease, a brain disease, which can be treated, and the people who suffer from it are not weak, but they need our care and our support. But this is an older picture from 1982. We've been at this location for over 40 years now. And nowadays, Jellinek is not just a clinic that treats addiction, but an expertise center for drug use in general. We have many different locations in Amsterdam, including detox facilities, a center for specialized dentistry for people who, because of their substance use and the lifestyle associated with that, have problems with their teeth. And as I mentioned, we have a big prevention department where Raoul is a part of, where we try to communicate information to people, for example, young people, parents, families, about how you can prevent harmful drug use, recognizing that drug use is always going to be going on in society. That cannot be fully prevented, but with the right information, you can at least prevent harmful use and can also prevent it from developing into addiction. So that is just a bit of background about Jellinek. So I want to get started now by discussing some common drugs and their main effects. You can kind of divide most substances into three different categories, starting with stimulants. And I think many of them will be familiar with, starting out with caffeine. Of course, many people don't really think of caffeine as a drug, but it is, right? It has a stimulating effect on the brain. It also includes nicotine. It includes amphetamines, right? Such as speed or methamphetamine, cocaine, MDMA or ecstasy, and then some newer substances like cathinones, 3-MMC, and a few lesser known ones, and some novel substances which are similar to MDMA. And we've seen in the Netherlands, but really all throughout Europe, that the last 10, 15 years or so, these newer stimulants are more and more available on the market. Oftentimes they're not illegal yet, according to the regulations in the country. So you can easily order them online. And from what I understand, some of these substances are also being used recreationally in Ukraine. These are not all of the different substance stimulants that exist, but these are some of the most common ones. Then another category is depressants, right? So instead of activating the nervous system, they decrease activity in the nervous system. The most well-known one, of course, being alcohol. Also benzodiazepines, which are substances that are prescribed for sleep and for anxiety, for example, like diazepam and many others. There are opioids like heroin, morphine, and fentanyl, and oxycodone, which are also prescribed very often in hospitals for pain treatment. And then there's of course also GHB and barbiturates. Another category, and this one is quite diverse, I should say, is the psychedelics, so substances that really alter consciousness and the way that people experience reality. I've included cannabis in this list. Now, you could argue that these substances here are so different in terms of their effects that it's kind of hard to group them into one category. But for now, just for simplicity, I have grouped them together because cannabis also has some more mind-altering properties. It also includes dissociatives like ketamine, which is also used in hospital care, but also recreationally. It includes psilocybin mushrooms, but also LSD, DMT, ayahuasca, and a few other types of psychedelics. And again, as I mentioned, while they are now in one category, their effects are very, very diverse. And we could have a whole entire webinar about their different effects, but that goes a bit too far for now. So just to focus a bit per category, what are the main effects of these different substances? There's the psychological effects. So in the case of stimulants like cocaine, amphetamine, and MDMA, what you see is increased alertness and energy, euphoria. So really feeling happy and good in the moment, feeling more social. And those are really the effects that people find appealing about these drugs, right? They are often used in party settings. And they make people want to talk to each other. They make people want to dance, right, and enjoy themselves. But it is also, of course, what can really make people develop a problematic use with these substances because they are so enjoyable that it can be really hard to try and control your own use. There's a few potential risks, psychological risks with the use of stimulants. It can induce anxiety or even panic, especially if you use higher doses or if you are a bit sensitive to anxiety. It can induce risky behavior, meaning maybe your normal sort of inhibitions are a bit less, so maybe you are a bit more impulsive. Maybe you make some decisions that normally you wouldn't. And in some cases, again, if you are sensitive to this, it can induce paranoia. So it can make people really anxious or think that people are against them. It can make people have some delusional thinking or even hallucinations. And especially with higher doses and with insomnia, if people are skipping sleep for multiple nights in a row, it can also induce some psychotic symptoms. Which usually fade away again in most people once they get some sleep and they return to their normal rhythm again. Then there's the physical effects, which kind of speak for themselves. I think increased heart rate and blood pressure, dilated pupils. People tend to have less of an appetite, so they are not really eating as much as they normally would. Sweating, jaw clenching, especially with drugs like MDMA. This is something you can see very often. And insomnia, because it's hard to fall asleep due to these effects. And so for this reason, the physical risks that you see with these substances are strain on the heart. It can induce arrhythmia at higher doses, or if you have a sensitivity for this. And it can also lead to overheating and dehydration, which is not just due to the substances themselves, but also the settings in which they're often used. So you can kind of imagine a whole night of dancing, not really paying attention to your food and drinking as much. People run the risk of these effects as well. Then the depressants, as I mentioned, that includes alcohol, sleeping medication, and also opioids and GHB. So the general psychological effects that you can expect with these substances are a feeling of sedation and relaxation, reduced anxiety and inhibition, especially with alcohol and GHB. You can see that. Also some euphoria. And again, these are the effects that people are often really looking for recreationally. In the moment, it makes you feel just a bit more loose. If people experience anxiety or tension or stress, it can make these substances very appealing to use because it provides some temporary relief from these complaints. It also leads to problems with cognition, sometimes like your memory and concentration. Your speech is affected, and especially with regular use, it can lead to emotional detachment. Some potential risks, again, especially with alcohol, risky behavior and aggression. And I think we are all kind of familiar with, situations where people's behavior can really change with alcohol, where their usual inhibitions socially or in other ways are not really as as present as usual. So people can sometimes be impulsive and even aggressive. It can lead to memory loss and blackouts. And with these substances, there's a very high potential for dependence. So that goes for alcohol, benzodiazepines, opioids, and GHB. These are all substances where if you use them on a very regular basis, the body really becomes used to them, and the withdrawal effects can be quite severe. So what are some of the physical effects of depressants? Well, kind of the opposite of stimulants. So the breathing slows down, the heart rate slows down, blood pressure as well, drowsy feeling, and coordination problems. So these are also some risks that are present with higher doses in these substances. So with very high doses of alcohol, opioids, and benzodiazepines, you can imagine if the heart rate really slows down, the blood pressure really drops, that it can make people lose consciousness or sometimes even go into a coma. So those are some of the potential risks of overdose, for example. Especially with alcohol, there's a high risk for liver damage and other organ damage. And as I mentioned, with the withdrawal, with these types of substances, the withdrawal can be quite risky, especially if it's too abrupt. So if people are drinking very high amounts of alcohol for a long period of time, and sometimes people decide kind of impulsively to quit, it can lead to seizures, it can lead to people becoming delirious, and it can lead, of course, to accidents and injuries because of risky behavior. Then there's the psychedelics, as I discussed, very diverse: ketamine, psilocybin, LSD, and also cannabis. The main effects that we see with psychedelics are on the psychological side of things. It alters people's perception. For example, visually, people can see the world in a different way. They can see visual effects like colors or shapes. It can really alter the way people experience time, space. It says here ego dissolution. That might sound a bit abstract, but people can kind of lose a sense of who they are in one of those experiences. Emotions can be experienced very strongly, and sometimes people experience that they can reflect a bit deeper about themselves and have spiritual experiences. That is also one of the reasons why some of these psychedelics are now also being studied for their therapeutic use. For example, ketamine being used for the treatment of depression now, and other psychedelics being used for other mental health problems. So that's, of course, on the positive side of things, but you can also imagine that these effects can also be very distressing or scary in people that are using them in recreational settings. So people can experience anxiety and panic, really strong confusion, or kind of forget who they are and kind of lose a grip on reality for a while. Now, in most cases, I should say that does resolve again. So after the effects of the drug fade away, in the majority of people, these effects do not last. But if you have a very strong experience or if you have a sensitivity to it, sometimes it can lead to flashbacks, and people keep experiencing hallucinations for a longer time, several weeks or even several months. Then there's the physical side of things. With many of these substances, the psychedelics, the risks physically are not as high, actually, as with many other drugs. Maybe slight changes in heart rate and blood pressure. People can become a bit nauseous, and their coordination might not be as good. But in the case of, for example, cannabis or LSD or psilocybin, the drugs themselves are actually not that toxic to the body. There's maybe a slight exception when it comes to ketamine, because we know from ketamine that very regular repeated use can actually cause problems with the bladder, where it really damages the tissue in the bladder and can sometimes cause severe pain and might even require people to go to the hospital. And what's really kind of challenging for people that experience this is ketamine is also an anesthetic. So people experience a lot of pain, and it can cause them to use more ketamine to sedate the pain, which then gives even more bladder damage in the long run. So it's a very hard cycle for people to break through. So that's just a bit of an overview about the different drug effects. And what I should also mention, and I think this is very important to understand about any type of drug use, is that the effects of a drug are never just about consuming the drug itself. There are several different factors that are very important in the effect on the individual. So there's this little pyramid model that you can see here that contains three elements. So there's the drug itself at the top. So that's the type of drug, but also which dosage you're using it in. The purity really matters, right? If there are other substances mixed in as well. And another factor that really matters is the way that you're using it. Like, for example, with stimulants, you can snort them, but you can also ingest them orally. Sometimes people inject these substances. And one sort of rule of thumb is the quicker the effect kicks in with the drug. So, for example, with smoking and injecting the drug, the effects are nearly instant, and they also last more briefly. The potential for drug abuse is way higher because people keep wanting to chase that same effect, and it really has a sort of a hard crash when the effects wear off again. So there's a higher potential for repeated use.
Dear Keenan, I'm sorry to interrupt you, but participants say that the translation is lost.
Oh, okay. Should I pause for a moment?
Yes, just please pause for a little.
Yeah, no problem.
Команда технічної підтримки, підкажіть, будь ласка, чи відновлено переклад?
Так, чутно, дякую. Так.
Okay, thank you, Keenan. We can proceed.
Okay. Should I maybe repeat anything of the last minute for the translation?
Yes, please.
Yes, maybe just a sentence.
Okay. Yeah, I'll just for the translation, I'll repeat the last thing I said. So I was talking about the method of use, that is very influential for the potential for addiction, because one sort of general rule is the more quickly the effect of the drug kicks in, for example, with injection, it goes immediately into the bloodstream. And with smoking, it's also a very quick absorption into the body. The potential for abuse is a lot higher because the effect kicks in almost instantly, but also the effects wear off more quickly. So it can really make it so that people keep wanting to chase that effect when it wears off. So that is also a factor that matters a lot in the potential for addiction. So then another important factor here on the bottom left is your mindset, or we call it set over here. So that is, what intention does someone have for the use? So it can be purely recreational. Maybe people are using at a party. Sometimes people are using at home alone just to deal with their stress or with their emotions. And that really influences what kind of effects people are experiencing from the substance. So your emotional and your psychological state matter quite a bit for the subjective effects. just like your overall stress level matters a lot. But also your physical state. If you are experiencing physical illness or discomfort or unsafety, that is also something that is really gonna have a large impact on the way you experience the drug. And then finally, here in the bottom right, we have the setting, which is the direct physical environment in which you're using. Again, like I said, it can be at home, it can be at a party, but it can also be in dangerous situations, right? Sometimes people who suffer from addiction are living in circumstances that are very unstable or unsafe. Sometimes it's out in the streets, or maybe it's in houses with other people that are using, maybe in care facilities, where, of course, if you feel very unsafe physically, that is also really going to affect the experience. The social group in which you're using matters quite a bit. If you are in a group of people that you feel safe and comfortable with, or where there are certain norms around the drug use, especially for young people, right? Sometimes they are in friend groups where it's really encouraged to use drugs. But sometimes the opposite is true, that in the group, there's actually a lot of social control. Meaning if someone goes a bit over the limit with drug use, maybe other people will say something about it and kind of limit them a bit. But then there's also the societal context, right? So what's going on in the culture, what's going on in the country. And I think that kind of goes without saying that when you are in a crisis situation in your country, and that is something that is constantly on people's minds, you can really imagine that that is really influencing people's experience with these substances. And just to make it kind of concrete, if you imagine drinking, let's say 5 units of alcohol, right? 5 drinks, can be 5 beers or 5 glasses of wine. If you are drinking them home alone by yourself because you are experiencing, a very low mood or high stress, that is going to produce a very different effect on you psychologically than if you are drinking those same 5 units of alcohol surrounded by your best friends, right? In a bar, having laugh, having nice conversations, listening to music. Those same 5 drinks are going to produce a completely different effect. And that is the case with any drug use. It always really depends on the context. So it's good to actually, for a moment, reflect on the different harms that drugs can produce. Now, this is a pretty famous graph, sort of in the drug research world, and for some people, it's kind of surprising actually. I don't know if this graph was translated for people that are listening in Ukrainian, but I'll just point out that this graph here shows the most harmful drugs according to different studies, from the most harmful all the way on the left here to the least harmful all the way on the right, where in red the graph says what is the harm to others, right? So to society, but also to people around the user. And in blue, it says it scores the harm to the individual themselves. And all the way on the left here, as the most harmful substance to the user and to others, is actually alcohol, even above heroin, crack cocaine, and methamphetamine. And people find that sometimes a bit surprising because, of course, alcohol use is so common. It's legal in most countries in the world. But we know from decades of research and, of course, from addiction care that the vast majority of people that are experiencing problematic use are experiencing problematic alcohol use. And it has very major effects on global health. Then if we look on the other end of the spectrum, we see that some of the least harmful substances are, for example, LSD, ecstasy, and well, a few stimulants that you can see over here in the middle. And again, it's kind of interesting because for many people, sort of by their gut feeling, they would probably say that LSD or ecstasy is probably a lot more dangerous than alcohol, because these substances are banned, of course. But if we just look by the research, it actually is not really supported. It's accepted that alcohol is far more harmful. Now, just very briefly, I won't get too technical here, but just so you get a bit of an overview of how addiction develops in the brain. There's a few structures in the brain that are involved in addiction, including over here the prefrontal cortex, which is really sort of the more advanced part of our brain, where it allows us to reflect, to think about our decisions, and to also inhibit our impulses, right? So we all have impulses all the time when it comes to food, sex, drug use, and other things that are rewarding. But we have the ability as humans to inhibit our impulses. But when it comes to drug use, especially the stimulants like we talked about, and also with alcohol, it can be very difficult to control your impulses because these drugs directly affect this area. And another thing that's important to involve here is the more deeper structures in the brain, the basal ganglia that's more deeper inside the brain, and it's an older structure in the brain that is more dopamine focused. So that is really where our motivation and reward system is present. And this older part of the brain is more impulsive than this more advanced part of the brain. So these deeper parts are not really capable of reflecting so much. They are more about immediately getting your needs satisfied. So these parts of the brain are essentially screaming, give it to me now, give me the food, give me the drug, give me the sex immediately. While it is fighting with this part of the brain that is trying to reflect and say, no, that's not a good idea. Let's wait, or let's not do this right now. And that is what people with addiction are constantly struggling with. So don't worry if this image looks a bit technical. I will just go through over here on the left. You can kind of divide the cycle of addiction into 3 different stages. So there's the anticipation stage, where people are really thinking a lot about when it's going to be the next time that they're going to be drinking, for example, or going to be using the drug, or even behavioral addictions like gambling or like sex addiction. So that's the stage where people are really already visualizing themselves using, or are making plans like going to a cash machine so they can get their money and give it to the dealer, or already thinking about like during their workday, thinking about that you can't wait to go home and start drinking again. Then the next stage, the intoxication stage, is where people are using whatever the drug may be, and they are getting the positive effects from it, whether that's like the euphoria or maybe a temporary relief from stress. And that is when that anticipation feeling is temporarily kind of relieved. And it's also the stage where people build up tolerance. So tolerance is the mechanism where the more often you use a drug, the more you need of that drug over time to get the same effects. The body kind of starts getting used to that drug. And then the stage after that is the withdrawal stage. So the effects of the drug are now wearing off a bit. And the day after, or even multiple days after the use, you see kind of an opposite effect of the intoxication stage, or a rebound effect, where people tend to feel emotionally and physically not well. Sometimes people experience withdrawal symptoms, and it can really increase stress, anxiety, and depressive symptoms. And that stage is very difficult for people to get through because what is very likely to happen is in order to deal with that increased stress, anxiety, and depression, it's more likely that people will just start at the top again and think about the next time that they're going to be using. And this is the cycle that we keep seeing over and over and over that is so hard to break through. And as just a final point for this section of the presentation, I think it's very important to note, like, when we're dealing with people in care that suffer from an addiction or substance use disorder, it's very common for people to say that it's just a lack of motivation, right? So there's a lot of stigma around addiction and substance use. Well, there's more acceptance nowadays in many cultures around mental health problems like anxiety and like depression, because we understand that that is not something people chose for, right? But when it comes to addiction, there's a lot more prejudice and stigma that you're kind of doing it to yourself, right? It's your own fault. And sometimes even in a care setting, it can lead to this feeling that why is this person not trying harder? Like, why do they keep going back into that same old pattern? And one metaphor I like to use is that when you're sitting in treatment with someone suffering from addiction, it's like there's a third person in the room behind them, constantly screaming at them, saying that other things are more important, distracting them, right? Making it very hard for them to break through this cycle. And in the vast majority of cases, it doesn't have anything to do with a lack of motivation. People want to make a change. People want to improve their lives. But because of all sorts of different factors like mental health problems, trauma, physical illness, or stress, they keep falling back into the same cycle because also the brain systems that are involved in motivation are kind of trained to respond to that way, to stress, for example. And it can be very frustrating also in care that you keep setting goals with people, you keep making appointments with them and setting intentions, and they keep relapsing. And as a caregiver, it can sometimes give this feeling like, oh, you know what, this person is just not trying their hardest. And sometimes that might be true, but from my experience, in most cases, people really want to change. It's just very, very difficult for them, and it asks a bit of patience from us. So I think that's the final point that I have for this part of the presentation. So I will pause here and yeah, check in if there are any questions from the audience. And Irina, will I be getting those over the chat, or is an interpreter gonna share them?
I guess both ways, but for now, I don't see any hands raised and no questions in the chat.
Okay, let me
Just
also
people
just open.
thanking you.
Okay, that's good. Just give it one more moment, but if there are no questions for now, then maybe we can also just go to the break, right? So I initially had a 5 minute break in mind. What do you think, Lena? Should we continue again in 5 minutes or 10 minutes?
Yeah, we can have a 5 minute break.
Okay, yeah. So for now, let's do a 5 minute break. If you need to get a drink or go to the bathroom, and then we'll continue in 5 minutes.
Great.
Okay. Yeah, thank you.
Шановні учасники, пропонуємо не залишати зустріч.
Dear participants, please do not leave the Zoom. You can just make tea or coffee and be back here in 5 minutes.
Okay, so ready to continue again. Are the interpreters also ready?
Yes, we are ready. Sorry, can you
можна зараз питання
can
задати?
can I ask a question right now?
Зараз можна питання?
Yes, of
Так.
course.
Стосовно прошлої теми.
I just wanted to ask about the previous topic. There was the conclusion that the system of the motivation in the brain does not work in case of stress. Is it correct? For example, that if the person is stressed out, then the motivation decreases.
Is that a question for me?
Yes, it's a
Yes.
question for you.
Did you hear that?
I did not get a translation for that,
Sorry, can you hear me right now?
but
Oh.
because I don't have the feed on. Should I have that one on?
Well, yes, if you choose the
О,
globe,
тепер чутно.
yeah, you can
Чутно.
click on the English interpretation and you will hear the translations of Ukrainian questions.
Okay, yeah, I don't have that one. One could let me see. 1 second. I just need to do that. The globe.
More the globe and then listen in
More.
English.
I don't see it actually.
Так, мабуть, я займаю чужий час. Не буду тоді. ладно.
Probably I'm taking up your time, so
Бо
we
це
will
не це
ask it later because that's not
Would it be
the whole
possible to just
question.
translate this question so I can answer it?
Okay, I
Can you
try to
hear
quickly
me?
translate it. The question was about the motivation. Is it true? Is it correct that in case of stress, the motivation reduces?
Yes. So it is true
Але
that
питання не
when,
в тому. Хорошо. Добре. Тоді,
All right.
дивіться, ми ж
Then
вживаємо, залежні люди вживають
the people with substance use the substances and relapse because they lack motivation to keep the recovery path. So stress prompts them to use the drugs. They use them because they cannot cope with stress. So our main goal is to learn how to live with stress and how to use constructive coping mechanisms without substance use. But how to do that without relieving stress? So the question is, do we need to put the person artificially in stressful situations so that they learn to tackle them without substance use? But it turns out that motivation in case of stress reduces. But how to deal with that? Should we put a person into stress on purpose in order to teach them? So could you please give the answer to this question?
So I don't have the translation feed, but I'm assuming that the question is about, is it true that stress can really affect motivation in a negative way, right? Is that kind of the main question?
The question was more about the fact that people use substance to relieve stress, and if we are going to treat them, should we put them in a stressful situation to teach them how to relieve the stress without substance, something like that? Yes.
Yeah. Okay. Yeah. So that's a good question. So exactly as you say, In many cases, people are using substances like alcohol, but also other drugs to relieve stress from mental health problems or from other difficult experiences that they have in their life. So in a way, they have taught themselves that they have this sort of method of, on the short term, dealing with stress. And it's absolutely a goal of many treatments to teach people how to deal with stress in healthier ways. Um, like, can be movement, it can be exercise. Sometimes it's things such as mindfulness. I don't know if we should necessarily be putting people in stressful situations on purpose. But it also really depends on what is the source of the stress. In a moment, I'm going to be talking a bit about PTSD and trauma. When people are chronically stressed from trauma disorders, it can actually be so overwhelming to them to be exposed to certain triggers that it is not really possible to teach them new behaviors, because every time they go out to that stressful situation, people go into a panic state, people sometimes dissociate even. So that means that people maybe need trauma treatment first before you can teach them new skills about dealing with stress. Yeah, that's. I hope that answers your question a bit, but I'm going to be talking a bit more about that in this part. But thank you.
May
So
I ask one more
Добре,
question?
дякую.
Would you mind if I continue sharing the presentation by myself, a Ukrainian version, just the same presentation like yours, but Ukrainian for better understanding of participants?
Of course, yeah, go ahead.
Okay, one second.
So I should stop sharing, right? Then.
Yes, please. I will say share the PDF version. Do you see the screen?
Mm-hmm. Yeah, I see it.
Okay.
Okay. I now also have the feed on for the English translation. But maybe an interpreter say something to me so I know if it's working.
Yes, it is in English.
Okay.
I can
yeah,
also see it in English.
Yeah. Okay. Great. Thank you so much. Okay, then we have that working. So you have the Irina, you have the Ukrainian version of the slides now.
One second, that's not that version. Yes, I have, but just give me one moment.
Okay. Oh, yeah, good.
Do you see the presentation?
Yeah, I see it.
And also, do you see the change in the slides?
Yeah, I see that too.
Right.
Yeah, so that's nicer for the audience, right? To be able to read the translation. So let me see, because I also have my English version here for the
It's
support.
slide 21, 22, I guess.
Slide 22. Okay, thank you very much. So then, yeah, let's pick it up from slide 22. And then I will just ask you, Irina, to go through the slides. So
Yeah.
thank you very much. So let's continue then. So for this next section over here, I want to talk with you about treatment options for addiction. And in the title, I put Beyond Detox. And the reason I did that is because a common idea that people have about treating addiction is that the goal is just to detox, right? To make sure people quit using whatever drug it is that they're using, and as long as they can just stop, then the goal is achieved, right? But actually, for many people, that's just where it starts. Like the actual work begins, because in the vast majority of cases, people that are suffering from addiction have underlying mental health or physical health problems that need to be addressed. So if you can go to the next slide. We have a bit of an overview of this is the way that treatment is structured at Jellinek. So on the left, we have the intake, and you can do an enter, which includes, in our case, also a screening for ADHD, PTSD, and psychosis. We screen for ADHD and PTSD, post-traumatic stress disorder, because we see that those are very common in people that have a sensitivity for substance use disorders. And it also includes a medical screening, because we know that with chronic substance use, it can also really influence your physical health. So it's not just about finding out how much someone is using, but also how it's affecting them physically. And then the next stage is the detox. You can do it. Yeah, exactly. Thank you. So depending on the medical screening, there will be an advice for either a medium care or a high care detox. So that is inpatient care, meaning people stay with us for 1 to 2 or sometimes even 3 weeks, depending on how severe the substance use is. And sometimes we also do outpatient detox. So people that are maybe working or that are somehow not able to be away from their home for a longer time, we detox them with the help of medication, and they might come multiple days out of the week. Then there's diagnostics. Next one, because after the detox, we sometimes see one step back, actually. So in most cases, we see if people are detoxed from whatever the substance is that they're using, many of their physical and mental health complaints actually really improve. But sometimes we see the opposite. Sometimes we see that it worsens. So people have increased anxiety, increased depression, or it becomes clear that all this time they were actually trying to suppress other underlying problems, and that can mean that we do diagnostics. So a psychological assessment. And I've included some of the most common ones here: depression, anxiety disorders, trauma disorders, but also autism, right? So people with autism, as you probably know, have a different way of processing the world, and can sometimes become very overstimulated and frustrated or anxious from being different. Sometimes people with low IQ also run into problems, and also people with personality disorders can have a lot of difficulty regulating their emotions and might be sensitive to substance use. Then the next phase, treatment. The large overview here, Jellinek is kind of an exception because we offer a lot of different modes of treatment, like cognitive behavioral therapy, acceptance and commitment therapy, 12 steps, motivational interviewing. But I realize that for many places, they are not able to offer so many different types of treatments. And especially with a care system that is really disrupted, right? It is my understanding that because of the war, so many aspects of the care system in Ukraine have been really disrupted. It might not always be possible to do extensive psychological assessment or a long psychotherapeutic treatment. So it might mean that there will be more reliance on medication or treatments that are easier to access, like motivational interviewing. I'm going to say something about that in a moment. And then finally, there's the aftercare stage. So we offer up to 6 months of aftercare support, which can be a phone call once a month or once every few weeks, or it can also be an in-person appointment to monitor how people are doing and see if they need any additional help, because we know with addiction that it's really about the long term. Because people will often have success with detox and treatment in the initial weeks or months, but then sooner or later life introduces new challenges. People get stressed out, people get triggered, and it can cause people to relapse. So we try to monitor this for as long as possible. And we can go to the next slide. So that's the detox procedure. So detoxing is about having medical support in achieving abstinence. It very often includes giving medication against withdrawal symptoms. And I mentioned it a bit earlier that for some substances, it's more risky than others. With alcohol, for example, it is often supplemented with diazepam, which is a benzodiazepine. And the reason that works is because these substances work on the same areas in the brain as alcohol, and it can help against withdrawal symptoms like shaking, like heart arrhythmia, and an individual treatment tapering schedule is set up so people can safely detox from alcohol. Another thing that is often done is people, it has really become the standard in the Netherlands to also give people thiamine, which is vitamin B1. And the reason for that is because what we very often see in people with severe alcohol problems is that there's also problems with nutrition. So people are not eating enough food because there's a lot of calories in alcohol, and it can cause people to sometimes not eat for days or barely eat for weeks, which can mean that there is a deficit of vitamin B1 in the brain, which can lead to Korsakoff syndrome, which I'm going to talk about in a moment. With opioids, people often get started on other opioid treatments. With benzodiazepines, people are converted to other benzodiazepines. And with GHB, the same is true. People get a controlled dosage of GHB. But people also get education about drug use, about the risks. They get nutritional support. And what's very important is we try to coordinate the detox with the treatment so that there's not too big of a gap in between the detox and the treatment. So you can imagine if you are detoxed after years of substance use, but you have to wait 2 months before your treatment starts, there's a very high chance that you will relapse again. So we try to have those things as close to each other as possible. We can go to the next slide. So that's this is a pyramid. Oh, I see it was translated. That's good. A pyramid that shows the highest risks of withdrawal with different categories of drugs. So at the top of the pyramid are the drugs that are the most risky when it comes to withdrawal, with GHB being completely at the top. And what we see in people who are really severely dependent on GHB is that after a while, they need to use almost every hour or every 2 hours. So even when people go asleep, they need to wake up every 1 to 2 hours because the withdrawal is so severe. And if people wait too long with getting another dosage, they can get very severe shaking, they can get seizures, and sometimes they can even go into a coma and die. So that's why GHB is so high on the pyramid. But the same is true for the withdrawal of alcohol. Now, this is especially the case with really high amounts of alcohol. So then we're talking about 25, 30 35 units a day, which can be, for example, a liter bottle of vodka, which is around 30 units of alcohol, or maybe even more. When people are drinking those amounts of alcohol, if they were to suddenly stop, it can be extremely dangerous. So we always advise to take it slow and go only in steps of 10% per week, which sounds like very little, right? But that's because it can be very dangerous if people go down too quickly. So what are some of the signs of alcohol, benzo, and GHB withdrawal? I mentioned a few of them already. It can be very intense shaking and sweating, can be very severe heart palpitations, anxiety, aggression, and seizures. And in some of the most severe cases, it can be delirium. People become very confused and hallucinate even. So if that happens with alcohol or benzodiazepines, what you want to do is start as quickly as possible with diazepam or whatever you have available as a benzodiazepine to fight the worst, the withdrawals. Those medications don't work as much with GHB. And it might sound strange, but the best way to do it with GHB is to give GHB. But I don't know if that is actually available in most places. I assume it's not. And then benzodiazepines can have some effect. With opioid withdrawal, it's a bit different. We see muscle aches. People can be very ill. And people sometimes describe it as having a very intense flu, where you're very nauseous, you have diarrhea, anxiety, and people can experience very, very intense cravings that just completely take over everything. So these are some of the signs to look for in different types of withdrawal. So we can go to the following slide. So I mentioned it briefly for a moment, the Korsakoff syndrome or Wernicke-Korsakoff syndrome. So this is a very severe brain disorder that can happen in people that show chronic alcohol use. And as I mentioned, it is not just the cause of alcohol, but it's the combination with very poor nutrition. So people are drinking all day and barely eating anything, and it causes an acute lack of thiamine or vitamin B1 in the brain. And it's divided into two stages. So stage one is what we call a Wernicke encephalopathy, which includes difficulty walking. So people lose coordination. That is one of the earliest signs you want to look for. If someone describes to you or you see in the treatment that there's a sudden change in how someone is walking, like people are very unsteady, and it's not just from being drunk, then you should be kind of alert that that is something that could be going on. People can become very confused, and people can start to show nystagmus, which is abnormal eye movements. So people might know this from like neurology exams. One of the ways you can evaluate this is by having people follow your finger, and the eye movements should be very smooth, right? So you can really see that people's pupils are smoothly following your finger. If it's very sort of disrupted like this, then that can mean also an early sign of Wernicke encephalopathy. So what needs to be done as soon as possible in that case is that you start giving vitamin B1. And a nurse can do that, a doctor, a psychiatrist, if it's available, of course. But that is really one of the first things that you want to do. If that is not done on time, and people continue with the drinking and the poor nutrition, it can develop into the next stage, which is Korsakoff syndrome, which is chronic brain damage. And the tragic thing is that at this stage, it is no longer reversible. And what we see in people that develop this disease is very severe memory loss. Often people can no longer form new memories. And what is very typical with this disorder is that people confabulate, which means they start making up stories, which is the theory is that because of all these gaps in the memory, it creates sort of error in the brain that needs to be filled up by other information. And it can be very confusing to people's friends and family or even caregivers when people start telling stories that never happened, right? Saying that well, it can be anything, right? That they went somewhere for the weekend, or they start making things up about their past, even though that never happened. And what we also see is apathy, meaning people sit in the chair, sit on the couch, and are no longer able to activate themselves. So what you can do, of course, is try to prevent it going from bad to worse, again, with treating the addiction and giving vitamin B1. But unfortunately, once it has progressed to this stage, it can no longer be treated. And sometimes people end up in nursing homes because of that. We can go to the next one. Yes. So there's several different treatment options that we have, which includes medication, which you can divide into antagonists, meaning drugs that go against the craving. Camprosate, naltrexone are often prescribed. There's agonists, which I mentioned, which help with the craving. So diazepam for alcohol, for example, and methadone for heroin. And when people want to quit smoking, we give them nicotine patches and tablets for the craving. And with alcohol, there's one particular medication that is kind of unique in the way it works. Maybe some of you are familiar with it. Disulfiram is what it's called here. What it does is it blocks a certain enzyme in the liver that metabolizes alcohol, so that when you give this medication and people drink alcohol, it makes them very, very ill, meaning it can cause them to feel very physically ill, like in their stomach. People like become very hot and anxious and get headaches. And it's a very severe, well, I should say it's a very strong medication that is kind of risky also, because even if you use deodorant with alcohol, or even if you eat chocolates that contain alcohol, it can already make people very ill. So it is usually not the first option. But if people are really chronically using alcohol and nothing else is working, you can consider giving this medication, but usually not as a first option. So then there's behavioral therapy, like cognitive behavioral therapy, which is very common. Newer therapies like acceptance and commitment therapy, and also motivational interviewing. And then there's also peer support groups. Next one. Which is not necessarily the same as individual therapy, where you start to work on your own thinking and behavior patterns, but it's more about support, being in a group of people that are also suffering from addiction or other mental health problems. And I don't know how many options there are in Ukraine, but one of the most common ones is Alcoholics Anonymous or Narcotics Anonymous, where you often don't have to register for these groups. They are organized at specific times. People can walk in and feel free to share just as much as they want and exchange stories and provide support from a very non-judgmental place, just making sure people don't feel alone, because for many people suffering from addiction, they feel very alone. So that is something where if regular care is not available, these support groups can also be very helpful. We can go to the next slide. So I mentioned it for a moment, motivational interviewing. So this is not necessarily a psychotherapy, but it is more of an approach in trying to have a open conversation with someone about what would be the benefits of changing their behavior. And the nice thing about motivational interviewing is that You do not have to be a trained psychotherapist or a psychiatrist to give this sort of guidance to people. It's not necessarily a protocol, but it's more about an attitude in how you discuss the substance use with the individual. That is all about empathy, right? So trying to listen to someone's story, how their substance use came about without having any judgments about it. Because people that are addicted have enough judgments of their own, or maybe they're already judged by their family or their friends. So what they really want from a caregiver is to be supportive and not be another person that is also judging them. So discrepancies, the next point, is about really helping the person see how their current behavior differs from their goals in life. So for many people, their addiction is preventing them from being maybe the parent that they want to be. Maybe they're not functioning as well at work. Maybe it's preventing them from achieving other goals. And it's about exploring together what would be the benefits for them personally if they made a change. So the next point is resistance. So it's my advice would be to try not to argue necessarily with the person, not trying to push them. Maybe you have your own ideas as a caregiver about what people should be doing, or maybe it's not going quickly enough. And while it can be challenging, I would generally advise to try and see if you can adapt to someone's own pace, and be a bit gentle about it. Sometimes you need to be stern, of course, right? Because people sometimes kind of contradict themselves or really need someone to be a bit stern with them. But as a general attitude, I would say try to be a bit gentle in the way you discuss these things. And also don't just focus on someone's problems, right? How everything is going wrong, how they are ruining their life with substance use, but also really try to explore someone's strengths, right? So maybe someone has functioned a lot better in life not that long ago. Maybe someone has a support system, and maybe they really need someone to motivate them to feel that they can really make a change in their life. And as I said, this method can be applied by any care professional. So just a few concrete things, right, to really make specific. It really helps to ask open questions like, what worries you about your drinking, right? So not having your own judgments about this ready, but trying to explore what someone's own motivations are. Affirmations, so letting the other person know that they are doing their best, right? Because that's very hard for people to see usually. So confirming that you see that they're trying. Also reflecting, right? If people is in a dilemma, or if people are having difficulty understanding their current situation, try to offer them a reflection and let them know kind of what their current situation is from your perspective. And also summarizing. That's really helpful for people to kind of order their thoughts. For example, okay, so you've been thinking a lot about reducing your drinking, especially because of your health. And that can give clarity to people about what is the most important to them. So then for the next part, we can go to the next slide. So for this section here, there's a lot of different psychiatric disorders that we could be focusing on that are common with addiction, but I wanted to dedicate this section a bit more specifically to trauma, because it just from all the clinical experience and research, we know that if one of the most common underlying problems that people with addiction suffer from is past traumas, which doesn't always have to be PTSD, post-traumatic stress disorder, but it can also just be a very, very difficult life, growing up in very difficult circumstances, or currently living through traumatic events. And this is a very popular quote by a Canadian psychiatrist, Gabor Mate, who said, "Don't ask why the addiction, but ask why the pain." And I think that's a very good thing to keep in mind when working with addiction. So these are some of the core symptoms of post-traumatic stress disorder in the DSM-5, which you can categorize into intrusive symptoms. That means people are experiencing very distressing memories about the thing that they witnessed or whatever it is that happened to them. It can manifest as nightmares, flashbacks, or very strong emotional distress when people remember the trauma. Because of this very strong emotional response, people tend to really avoid certain situations that make them remember the trauma. So let's say a traumatic event happened in a certain location, people will avoid going to that location. If people listen to a certain music or even talking to a certain individual, and it gives them this stress response, they might just completely avoid that situation altogether. And of course, if they are thinking about the trauma or the memory, they will try to use all sorts of ways to suppress that by drinking, by using substances, just to temporarily make them forget. This chronic stress from the trauma causes very strong changes in people's thinking and mood. People tend to have very negative beliefs about themselves or about the world. Thinking that people are all bad, that nothing will ever get better, or that they are weak, or that they are worthless. It can really distort people's view of themselves and other people. And sometimes it can lead to people being very emotionally detached. And some very common emotions are shame, feelings of guilt, fear, and anger. Another category, the final one that is very common in people with PTSD, is hyperreactivity, that is more physical, meaning people are constantly feeling tense. It can even mean people actually have like a higher heart rate or blood pressure. People can be easily startled by sudden noises, and have a very low tolerance for frustration, right? So if people are impatient, or if you just push someone a little bit too much, they can already have an outburst in anger. And it can also lead to very self-destructive behavior. So trauma can manifest in many different ways, but these are some of the most common ones. So just a bit of statistics for the next slide. We know from research that people with PTSD, around 30 to 60% of them will at some point in their life also develop a substance use disorder. And the other way around, we know that for people that are seeking help for substance use disorders, around 25 to 50% currently meet the criteria for PTSD. So that's a very large proportion, right? That's really something to think about, that so many people that are struggling with addiction really need help with addressing their traumas. And the final point, and I was actually very shocked by this statistic. I didn't really encounter that one before, but adverse childhood experiences, so very challenging childhood experiences, can really extremely increase the risk of substance use. And one statistic I found is that 4 or more of these challenging events during childhood can increase the risk of substance use problems by over 1,100%. And in the next slide, I have just a few examples of what these types of experiences can be like. Some of the most common ones, of course, there can be physical or sexual abuse, emotional abuse and neglect. So growing up in an environment where your parents or your family have not shown you the care and compassion that you need. It can be witnessing domestic violence. If you have one or more parents that struggle with mental illness of their own, being a witness to substance use within your family, divorce, physical assault, sudden loss of people, major disasters, and of course, war, combat, and forced displacement, right? So I think that kind of goes without saying that being in a situation where there's a constant threat of violence, of not being safe, of needing to leave your home and your stability. And sometimes people experience these periods multiple times in their life. And there are probably people that have experienced every single one of these points that you see over here. So you can imagine with that amount of trauma, it really requires a lot of care and support to help people process that. And for the next slide, I have just a few examples of how trauma responses can be present when you have someone in treatment. So the first one is strong emotional reactivity or withdrawal. So let's say you are talking to someone with a substance use problem, and there might also be trauma-related issues. People can sometimes become either very angry with you or frustrated or shut down completely. And sometimes you can actually see it changes a look in someone's eyes where you talk about a certain subject, or maybe the stress builds up too much in the conversation that you can see someone just kind of pulling away and being very distant. Sometimes you can also see it in the way people talk to you, that they'll say, you don't really care, nothing helps anyway, or I don't trust you, right? And you can, it's hard sometimes not to take that personally, but you should try to keep in mind for many people, maybe they grew up in an environment that was very unsafe, and they were mistreated by people, and so they have a reason not to trust others. So it's good to try and not to take that too personally. Then the next example is avoidance or difficulty discussing emotions, which really is sort of a protective response to survive. And it can be subtle sometimes in conversations where maybe as a caregiver, you want to talk to someone about things that they experienced in the past. And they'll say things like, oh, I actually don't really remember much. Or, you know what, it wasn't so bad. Let's just move on. I don't really want to talk about that anymore. And of course, sometimes you need to respect that if right now someone really doesn't want to talk about it. But it's also sort of a survival response because people really don't want to go there. And sometimes gently, it is necessary to slightly test if it is possible to have a conversation with the other person about these things. But of course, it's good to feel where the boundaries are. The next one, hypervigilance and distrust. As I said before, those are common with those physical symptoms. Sometimes you can see it when you interact with someone and they are constantly watching the door or checking their surroundings. Maybe there will be a sudden noise outside, like a siren, or people shouting, or, well, maybe even gunfire or explosions in the distance. You can really see like a physical response where people almost jump out of their chair. And that can be a sign that someone is experiencing PTSD symptoms. It can also express in people feeling really controlled, especially if people were abused in the past. And maybe they feel you are being a bit directive, right? If you are saying, okay, now I need you to do this or that, it can cause people to become angry at you, saying like, don't talk to me that way, right? You can't make me do anything. And again, it's hard not to take it personally sometimes, but it can really come from a place of not, well, having difficulty trusting other people. So it might mean you need to slow down a little bit. And then final one is difficulty with boundaries or attachment. So that is kind of the other side of things where maybe people are not really distant with you, but someone actually feels safe with you as a caregiver and become really, really attached to you. So calling you all the time, bringing you gifts, and you can sometimes feel it as a caregiver. And I even have this myself, right? As a therapist in in this setting we have over here, sometimes you can really feel like you want to save the other person because they are so dependent on you, and you want to give everything you can. But that can also sometimes be a consequence of trauma, where people did not receive the right amount of care and support early in their life. And now that they are finally getting that from someone, they can really latch onto you and not let go anymore. So in those situations, it's also important as a caregiver to check where your boundaries are. Okay, so the next section. So again, to just make it a bit concrete, how can you work in a trauma-informed way? Creating physical and emotional safety, which can already really help if you just explain the routines, right? If you have an appointment with someone and you have certain things you want to discuss that day, it's really good to mention, like, okay, today I would like to talk with you about this subject. We have 45 minutes for this appointment. And to really make sure that people know who you are, it's good to introduce yourself. What is your background? Right? What is your goal? Because people can sometimes be very distrusting of caregivers. It's important to also respect physical space, right? If people want to have a bit of distance, maybe they are sitting a bit farther apart from you, make sure that you respect that, and also provide some reassurance, right? Saying that it might be hard to talk about some of these things, but let's just see how far we get. And the next one is autonomy and choice. For many people that experience a severe trauma, they were often in a situation where they felt very powerless, like they were maybe dominated by someone else or abused, or were in a situation that they could not control. And what is really helpful as a caregiver is if you give people a feeling that they are in control, right? So asking them if it's okay to talk about a certain topic, even asking, what would you like to talk about today? Offering them options, right? So for the treatment or any other type of care that's necessary, make sure to give people options so they feel that they are in control and you're not just another person telling them how to live their life. Next one, collaboration. Really trying and figure it out together, right? So people can really find you an authority figure, right? If you are a therapist or a nurse, or people will sometimes really look at you to tell them what to do, but try to really encourage collaboration, saying we're doing this together. Next one is empowerment. Mentioned that before. To not just focus on someone's problems and how everything is going wrong in their life, but also really reminding them that they already came a long way, that they're strong, right? And trying to find out what are someone's strong sides. Maybe they are intelligent or creative, or have a really strong sense of responsibility. Then try to also highlight those things. And the final one, trustworthiness, a very important one. If you make appointments with someone, keep to your word, right? So make sure that, and this is, I realize this is a challenging one because it's already difficult enough being a caregiver in the current situation. But it's really important for people to know that they can rely on you. So make sure that you keep your word, that you explain your role, and that you also follow up with them so that they know they can rely on you. Then the next one, I also really wanted to include this section over here, because I realize for so many of you and your colleagues, this work is already difficult enough, right, or challenging enough when you're not in the situation where your country is in combat, and I can't even imagine what it's like to also have being available and giving care to people who are in such distress. So I just wanted to include a brief section on how you can also take care of your personal well-being, which is recognizing when you are heading towards burnout, or what we call compassion fatigue, which means something like really not being able to be present anymore with the other person. And you might notice from the work day in, day out that you feel kind of emotionally drained. Maybe you're a bit irritated or detached. So not really being in tune with the other person anymore. It can also be the opposite, that you're actually overwhelmed by others' pain, right? If you're constantly exposed to people who are in such difficult situations, that you really start absorbing that, taking it home with you, right? Noticing when at the end of your workday, maybe even having difficulty sleeping at the end of the day because you keep thinking about everything that these people are going through. And of course, feeling like you are never doing enough, right? You are all in the field of care, so you really want to help other people, but it can really feel like it's never enough. But it's good to recognize when that is happening. There's small things you can do that can sometimes make a big difference, like anchoring yourself, which can be even just 5 minutes of silence or conscious breathing before and after work. Sometimes people have a simple mindfulness practice. It can be with an app, it can taking a walk, and it might not sound like much, but doing that in a conscious way, right? Taking breaks, breathing, and anchoring yourself with both feet on the ground again can be very helpful in staying in the here and now. The next point, very important also to connect to others, right? Try where possible to also open up to other people. If you are working, with your colleagues under difficult conditions, try to relate to each other. It can even help to create a peer support group if possible. Even if you do a 15-minute check-in once a week, or maybe even at the start of the workday, right? Whatever is possible, it can be helpful to really try and connect with each other in that way. And also laughing together. I've met a few Ukrainian people, and I think they have a great sense of humor. And I also think, in general, when working in this type of setting where you're exposed to very difficult, sometimes very dark situations, it's actually very necessary to sometimes be able to laugh about how crazy things are, and to laugh together as well. And I really think humor is actually very important here. And then finally, I mentioned it before, also setting your own boundaries, as I mentioned, and it might sound, kind of tough, but you cannot save everyone, right? There's limited resources. Sometimes you want to give someone the whole world and all of your attention, all of the time you have, but unfortunately, sometimes it is simply not possible to completely get someone out of their situation. But your presence matters, the work you do matters in so many ways that are not always directly visible to you. But sometimes one thing you can say, or just being present with someone, can really make a really big difference. And finally, just take breaks on time and make sure that you take care of yourself so you can get back to work. Because if you fall into a burnout and because you're constantly going over your own limits, then that means you will not be able to help other people out because you need to take a rest for weeks or sometimes even for a longer time. So as a take home message, try to also really take care of yourself in these times and of each other. So that's my final point that I want to give you for this part. And then again, there is time now for questions. And thank you for your attention.
Yes, Kenan, there are some questions in the chat. Maybe we should address them first. And there are two questions. They were directed to you. Maybe you can read them and answer.
Yes, so
Do you
let
see them?
me, yeah, let me see. So I see them in Ukrainian. One of them is in English.
Okay, I can
So
just read it out loud for you. There are two questions translated already.
yeah,
The
yes,
first one
please.
is who diagnoses ADHD and what tests are being used.
Oh yeah. So we have a screening questionnaire that has only 6 questions for ADHD, and it's called the ASRS. I can put that in the chat, actually. I don't know if it's internationally recognized. I will put it here in the chat. And that is not the same as a full ADHD assessment. It just includes a few questions to see if there is a chance that there is ADHD. And if you wanted to do the full assessment for ADHD, we use the DIVA. Put that in the chat as well, which is a DSM interview for the symptoms of ADHD. And that takes a bit longer. That takes around an hour and a half.
Right.
Yeah.
The second question was from Valentina. So when a patient tests your trust and brings gifts, what should you do? Set boundaries or accept there and pick up the phone to establish trust?
Yeah, it's a good question, right? So I did not necessarily want to suggest that if someone is bringing you gifts, that is necessarily a problem. Not at all, right? It can actually be a sign that you have a really good working relationship with someone. But it can sometimes also be a sign that someone is really sort of becoming overly involved with you, focusing too much on you instead of on themselves. And I guess it also depends on the gift, right? So a box of chocolates, for example, is something very different than when people start bringing you like very expensive gifts or someone that doesn't feel right. And I would say to maybe communicate, right, in sort of a healthy way, like, hey, I really appreciate that you want to show your gratitude to me. But right, I doing this work is already its own reward. And to also really kind of trust your intuition, where if you're getting a gift from someone or someone is kind of doing something that feels like it's socially not really suitable, to kind of trust that feeling and to try and communicate to the other person in a friendly way that you really appreciate it, but you don't think it's right to accept their gift.
Thank you. There are also questions in the audience. Людмило, будь ласка.
Hi, I'm Ludmila. I want to ask you on English. Can I do this? Because I'm studying English.
All right.
I'm a psychologist. I'm from Lutsk, and I want to ask you about the work with teens, because I'm psychologist for teens, and I want to know about maybe a prevention work with teens who have problem with drugs and alcohol. This is the first question, and the second question was about self-harm. Can you have maybe early diagnostics moments to watch this problem and to help teen to support him or her with this problem? It's very very important for me, because I have some clients with self-harm. Thank you very much.
Yeah.
Thank you for your studying, and it's very interesting, and your voice is very, very good. Thank you.
Yeah, thank you very much. So it's 2 questions. So The first one is about teens and alcohol and drug use. I think Raoul can actually also say a bit more about that in his presentation. I mostly work with adults, but of course, when it comes to teenagers, what kind of sets them apart is usually their substance use habit has not existed for that long yet. It tends to start with experimentation. And because they're not adults, they usually live at home, right, with their parents or with other family. And it's generally helpful to also really involve the family in the treatment, which can also be a challenge because sometimes the child and the parent can also kind of trigger each other. But it might really require involving the whole family system there as well. And of course, a big difference between young people and adults is they have not yet fully developed yet, right? Their impulse control. They tend to have more of an adventurous spirit where they want to try new things, and cannot really oversee all the consequences yet of all their drug use, and how it can lead to habits. And I think education, like we call it, like psychoeducation, explaining to them a lot about the risks of drug use and when you call something a drug dependence, that is really, really helpful to try and help them understand some of these potential risks, because they're so young, many times they're not really aware of these things. That and also involving the parents. But I think Raoul is going to say a bit more about that in a moment. And then your second question is about self-harm. Yeah, that is something that, just like suicidality, for example, is a topic that is sometimes a bit difficult to discuss, right? Or maybe even as a caregiver, you can feel a bit hesitant to ask questions about this. But actually, in many cases, it is kind of a relief for people if they can talk with someone about these things in a safe way. Because very often people have these thoughts or these behaviors completely alone by themselves. And with self-harm specifically, which can be, for example, cutting, or it can be burning yourself, or sometimes it can be out of anger that people punch the wall with their fists. And even in a way, substance use in a very destructive way, where people know that they are really risking health problems, right? Combining a lot of different things or losing consciousness can also be a form of self-harm. But similar to the point about suicidal thoughts, I would say that it is good, actually, if you have any signals about that, if people are struggling with depressive symptoms, especially, it is good to open up that topic and that conversation if it's ever happened before, that people have self-harmed, if it's okay for them to talk about it. And maybe even if that is the case, explain a little bit about them, that very often self-harm is a way kind of regulating your emotions, because people often have so much pain and distress that it kind of goes everywhere at the same time. They're overwhelmed, it's chaotic. And what I hear from people often that self-harm is that what it does is it kind of helps bring it into focus. So your head is completely chaotic and overwhelmed. So people cut or burn or do any sorts of things to hurt themselves. So at least it's focused on one point, and that makes it a bit more manageable. So I think to summarize, I would say, yeah, try in a careful way to open up that conversation, and also explain a little bit to people about why self-harm can be a way to regulate your emotions. But like I said, very often it's actually a relief for people that they can finally talk to someone about it. Yeah. So I hope that's helpful.
Thank you very much.
Yeah, of course.
Дякую, Мар'яна.
Mariana? Hello, my name is Mariana. I am a psychologist, psychotherapist. I work in the rehabilitation center with people with substance use disorders for more than 25 years. I work with my own addictions program. So my first statement is any addiction, any substance use disorder is the compensatory mechanism for depressive conditions. I mean, depression goes always first before all addictions or SUDs. And this depression is the feeling of emptiness. In your program, do you study this internal feeling of emptiness? That's the first question. And what can you say about it? And the second question, this is the connection where the basic child needs were violated, which leads to the destructive form of the formation of destructions, personal destructions like hypersensitivity, idealization, and perfectionism. This connection of these destructive forms which lead to depression and specific temper, and which give the fast track to substance use disorder.
Yeah, okay, thank you. Yeah, so it's two questions, and I'll start with the first one. So as I said, in this presentation, I focused a bit more on the trauma side of things because it's such a common underlying issue, but it's exactly as you say. There's a bigger variety of underlying issues that people can have, including depression, including feelings of emptiness and disconnection, which sometimes, as you probably know from your own experience, can also be a result from past traumas. But I think that's very common in people that struggle with substance use, that they maybe feel that there's no place for them in the world, or they don't have a future, or they haven't found anything in life that they enjoy, right? And it can really lead to demoralization, right? So that's this feeling that your situation is never going to get better, right? It's hopeless, and there's nothing meaningful to pursue in life. And we know that some of the most protective factors for recovery is if people have meaningful things to do in their life, which can be a job, it can be volunteering, but it can also be having a family and a support system around them. And yeah, so often it's very tragic that I see people in treatment that don't just need psychotherapy, but they need family around them. They need connections. They need perspective on the future. And we cannot always give them these things. But just psychotherapy and even medication is sometimes not enough. People kind of need to find meaning back in their life. And there are also forms of psychotherapy that can help people explore that a bit, like their personal values and goals in life. But that is absolutely something that we also have attention for, which doesn't always just fall in the category of like psychiatric problems necessarily, but it's more like an existential problem almost, that people just don't really know what their purpose is in life. So yeah, we definitely pay attention to that. And your second question, if I understand it correctly, I mentioned it briefly that what's also very common in substance use disorders is personality disorders, which very often have to do with like problems with identity, regulating your own emotions. People can be very, very impulsive, and usually these, like you mentioned, these problems arise from like basic childhood needs not being met, like safety and support and emotional warmth from the parents. And exactly like you say, it can lead to very impulsive and self-destructive behavior. And in most cases, to work with these patterns, people need like longer psychotherapy, like maybe a year, maybe a year and a half, sometimes quite intensive, and sometimes even way longer than that. Because we're talking about patterns that have sometimes existed for 30 or 40 years. And just taking away the substance use actually really opens up like all of these underlying emotional and identity issues that people have. And then what you want is people to be able to go into this psychotherapy that they really need. But even here in our care system, that is a major challenge. And with relapse, it can be very hard to keep people in a treatment. But yeah, to summarize, ideally, you don't just want to focus on the substance use. You really want to look at these underlying deeply emotional problems as well. Yeah. Yeah. Thank you. Good questions.
Дякую.
Thank you.
Дякуємо, Кін. Маємо також ще
Thank
питання
you,
в
Kenan.
чаті.
And we have one more question in the chat. I will read in Ukrainian. How can we motivate a person to reduce alcohol use if the person combines sports and alcohol use?
Okay. So someone is combining sports and alcohol use. Does that mean, like, for example, sorry, sports or work? Did I understand correctly?
Sport.
Sports.
Sport and
Okay.
substance
Yeah.
use.
And so do you mean that someone is, for example, drinking after a game, like in a cafe or something?
Не уточнено. Можливо, Олена, ви
There
захотіли
is no
озвучити ваше
clarification.
питання,
Olena,
щоб
maybe you can
сказати
clarify
конкретніше.
that.
Так, я можу сказати
Yes,
конкретніше.
I can
Люди
clarify.
займаються
So
спортом, це не
people
гра.
do sports.
Люди
It's not a
займаються,
game. People
ходять в
like
качалку,
go to
людина
gym,
накачує собі
some
м'язи,
powerlifting
після качалки йде,
activities.
закуповує
And after powerlifting
алкоголь.
activities, the person goes and
Разом
buy
з
alcohol, and
дружиною
together
вони
with a
так
friend,
розважають вечори. І
not
так
friend, but
вже
wife,
триває
they
дуже багато
spend
часу.
evenings like
Тому
that.
я
And it's
запитала,
been
як
like
це
that
можна
for a long while. And
взаємодопомагати.
when I
Людина
asked,
говорить,
how is it
що
possible to combine that?
в мене
And the
зараз
person
дуже
says,
адреналін в
well,
спорті, а потім я
I
виходжу,
have a
щоб
lot of
вже
adrenaline in
мені
sports,
треба
and then I use alcohol
заспокоїтися,
to
мені
calm
треба якось
down,
так
and
врівноважити себе,
I need to
відпочинок, і
balance
це
up.
ще
And
багато
this way,
часу. І тільки зараз
it
людина
helps me.
усвідомлює, що в
And it's
неї
been like
не
that
може
for a
бути
while. And
незалежності
it's just
алкоголю.
now that the person realizes
Незважаючи на те, що
that he
вона
cannot
займається спортом.
stop using alcohol despite being in sports.
Okay. Yeah. Thank you for clarifying. Well, from what you're saying, I think there's already a very important first step that's been made, is that someone now has this insight that there's a relationship between the alcohol use and the sports, right? So this person is, in your example, powerlifting. It gives them a lot of adrenaline. It probably makes them kind of, energized and amped up. And apparently they have difficulty getting rid of that. And then, sure, in the short term, alcohol can probably help with that. So that's really step one, right? Is that someone recognizes that there's a relationship there. And then the next step can be exploring together what are some of the downsides, right, of that alcohol use. So asking them, what problems is that alcohol use causing? And again, like I mentioned before, kind of keeping that motivational interviewing attitude in mind, exploring together what are the negative consequences of the use. Really trying to clarify to the other person that this pattern has come about the exercise and then the alcohol, because that is sort of the function of it, right? The alcohol use, exploring the potential downsides of it, and then discuss what are potential alternatives, right? So the real problem that someone apparently has is, well, it's actually not, it's good that they have something for exercise, right? That's healthy. But the end result is this inner tension that they have, like the adrenaline, and then start exploring what are alternative ways to deal with this adrenaline rush. Maybe it can mean someone needs to pace themselves a bit with the powerlifting. Maybe it's their body telling them that they're kind of overdoing it. Maybe it means taking a walk, maybe a meditation practice, maybe they need to find other ways to relax, and then see if it's possible to have a conversation with this person, if it's worth at least trying new things. So without immediately telling them that they need to stop and they must now do these things, but see if you can get a willingness from them to at least experiment and try different things and see if it feels different. Yeah, I think that's what I can say for now. And yeah, just see if there's a willingness from their side to try alternative options.
Thank you so much. And I'd like to add, actually, he goes to gym to get rid of this emotional pressure, but after the powerlifting activities, he comes back home, he thinks that it's not enough, and he also removes pressure with alcohol. As one of my beneficiaries, she prescribed herself antidepressants, and then she was, drinking alcohol after taking them. And when I said that it's impossible to combine antidepressants and alcohol, how did you survive that? And she says, I'm surprised myself that I survived, but she said this is my escape way because the emotional pressure is so high that this way she's destroying herself. Thank you.
Yeah, well, again, another interesting piece of information there is, so apparently it already starts out with this emotional pressure that makes someone want to go and exercise in this way. And then I hear you saying that this person feels even that is not enough. So of course, without knowing the whole context, it immediately makes me curious, like, what is this underlying feeling of not enough, right? Like, I'm never doing enough. I always need to, like, what is that about, right? Is that, I think that would make me curious as a caregiver in trying to understand, like, why do you always have to be enough, or like proving yourself? Like, what is the origin in that, right? And maybe that is something that can be explored as an underlying theme. Is that also happening in other areas of life, like not just the exercise, but maybe also at work or in social settings? Maybe that is really something that needs to be talked about, this feeling of never being enough. And yeah, I would say take your time to explore that.
Мар'яна, прошу.
Mariana, thank you. Can I say something? May I comment out of my experience that usually this is the trauma where the person faced a lot of criticism. This like needs were not met, this perfectionism related to trauma, all of that will launch the insufficiency mechanism. EMDR therapy works well in this regard and helps remove these traumas and explores the mechanism of that. Thank you. Thank you.
Yeah, I think that's a very good addition. It's quite possible that is sort of the origin for that feeling of not being enough, that indeed someone maybe grew up in an environment where they were never enough, right? Where there was constant criticism. But in this case, of course, I don't know the full story of this individual, but it sounds like it would be worth exploring with them together what is sort of the origin of this feeling of being insufficient or not enough. And that might go back to certain experiences that they had growing up. Could be. Yeah. Thank you.
Дякуємо дуже за відповідь.
Thank you for your answers, colleagues. Let's take one more short 5-minute break. And after it, we will go back to the second session of this webinar. And if you have any other questions, I can see in the chat there is one more question. We'll get back to the questions after the break at 12:20. So see you in 5 minutes. Stay tuned.
Інан, чи ви вже з нами? Чи можемо продовжувати?
Can we continue? Kenan, are you here with us?
Так, дякую.
Oh, yes, I am here. I was waiting because for the next section, my colleague Raoul is going to do the next part, but I will introduce that. So this
Дозвольте
was.
запитати вас іще одне питання, буквально останнє.
Can we ask you one more final question that was written before the coffee break? And then I will start the presentation of the next session. Okay?
Sure. Yeah, of course. Yeah.
Питання від Володимира звучить
A question from Volodymyr is the following. How do you treat body practices of working on trauma like sensor intensified yoga as the prevention of substance use disorder or addiction?
Yeah, great question. So in the last few years, I would say there's been a lot more attention to also body focused trauma work. So not just focusing on all of the psychological aspects of trauma, right? Like things to do with self-image and behavior that is associated with that. But we really know from a lot of research and sort of influential thinkers about this, that trauma can also really sort of be stored in the body in all sorts of ways. People feeling unsafe in their own body, or chronic stress sort of being stored in the body in all sorts of ways. So I would say, if it's possible at all in the organization where you work, that these things can really be complementary with each other, where there's a focus on both the psychological aspect of things, processing, sometimes trauma treatment like EMDR or others, but also if there is the option to do body-focused work, which can be yoga, it can also be like psychomotor therapy in helping people understand their own body responses in relationship to trauma better, and learning ways in which they can feel safer in their body, that can make a lot of difference. Absolutely, because sometimes, I think in many cases, people are not even aware that this is still affecting them to this day, like their posture. Sometimes people are walking with their shoulders drawn all the way up, right? And until someone tells them, like, hey, did you notice, like, your shoulders are always completely up, and teaching ways how to relax your body. Yeah, I think we are not doing enough at the moment in mental health care to also involve the body. That is changing a little bit in a positive way, but yeah, I would really encourage combining psychological treatments with body-focused treatments, for sure.
Thank you. Dear Raoul, the floor is yours.
Okay, I hope you can hear me correctly. Well, thank you for the invitation. It's nice to be able to do something for all the people, for the people in Ukraine. From here, it's a safe environment, so we're happy to be able to do something for you. What I will be telling you is a bit more about prevention. So at the Jellinek, we do addiction care. And as Kenan already explained a lot about actual treatment, we also have a department that does prevention. So that's basically all kinds of circumstances, and for example, family members that don't need treatment but still need some help. For example, in the the parts that lead up to possibly to addiction. So I hope you can use some of the parts that I will be telling you about for your own practice, because we do quite a lot, so it's difficult to put it into a short time that we have, but I will do my best. So basically, prevention is we're trying to prevent problems caused by alcohol, other drugs, because often people forget that alcohol is also a drug. Gaming and gambling, and now also we're more talking about lately about screen time, like for example the use of your phone. But because that's causing also issues with the youth at the moment, at least in the Netherlands, probably worldwide. So we do that a few different ways. First of all, by providing information to the general audience. So, but also certain risk groups and professionals. So, for example, psychologists, teachers, yeah, many different people you were working in as a professional. So we try to provide information that's objective based on fact and that's not moralizing. And we also have the assumption that people, and especially adults, can decide for themselves how they relate to alcohol and other drugs and the effects and risks that they bring along. Often people think like if I go to the Jellinek for addiction care, I have to stop using, but that depends on the actual goal of the people that need help. So it could be to stop use entirely, but that's not always the case. If they want to use recreationally, we can also use that as a goal. We also do research, and we're trying to help destigmatization, because yeah, stigmatization still, even in the Netherlands, it's an issue that drives people from helping or finding help. So if they think like, oh, I'm seen as an addict, then I prefer not to ask for help, for example. And that's also one of the reasons why we have, as you see in the first slide, all these faces. So we're trying to show the general audience that addiction can happen to anybody at any time of your life. It has many different faces. So it could be yours, it could be your neighbor, it could be anybody. Yeah, it's just it's a destigmatization. Next slide, please. So one big part of prevention is harm reduction. So we all know, of course, that drugs cause certain harms. And the approach of harm reduction refers to different policies, programs, practices that aim to minimize the health impacts of drugs. And that can be physical, social, but also, for example, legal. Certain drug policies, certain laws can also have a harm for certain people. So we try to reduce these as much as possible. And we're not just focusing on the harms, but also on positive change, as Keaton also noted that sometimes it's good to show people what they still can do and what also is positive in the experience. So next slide, please. So what's important with prevention is basically the early detection. Sometimes we already see some issues with certain behaviors that indicate something more serious could happen later on. And if we tackle that right at the start, we could prevent more serious issues and damage later on in life. So early detection of issues is important in that sense. And if we do detect them, we can prevent escalation happening at a later stage. So what's important in the prevention and early detection is basically an integrated approach. Yeah, you can tackle just the issue of drug use, but often, as we already seen, there's a lot of other things happening. Could be mental issues, could be physical issues, or social issues. So, yeah, there's just an integrated approach is important. It's not just that person, but that person is part of a bigger whole. So we also want to integrate those persons and the other people around the person showing the behavior that is unwanted. So yeah, we also need to educate the surroundings about addiction, about drugs, about what it means to be addicted, what it means to use drugs. Drug use is not inherent on problematic. So sometimes it's recreational. It's could even be beneficial. So we want to, ask these people to cooperate and to also to share the knowledge with other people. And the people or the systems that you could think of is, for example, the care system. You could think about the general practitioner that can be integrated, but also other medical and mental health professionals. Sometimes, for example, safe houses or shelters where people come that are homeless, for example, but they often also use drugs. So, yeah, we can educate these people to, figure out if drug use is a problem, and if it is, to, see what they can do to help to make sure it doesn't become worse. But also the educational system. Schools, of course, are important, especially for youngsters that are still going to school, but also students, for example. They often, they're a bit more on their own. They might have friends that also use drugs. So then the family, parents, for example, are less inside. So it's important to keep track of what they are doing through schools. So it could be teachers, it could be other professionals at these schools to keep an eye on how the students are doing. And that's not just about drug use, but also about mental health in general. Local government can also play a role where, for example, the police, but also public service officers, people that keep track of certain neighborhoods, people that watch the streets, that are not necessarily police officers, but they still have a role to play in the policing system. So you can also educate them, make sure they are part of the whole system, because often they, for example, see people that are hanging out on the streets, like kids that are hanging out on the streets, and they can also play a part in preventing or figuring out if drug use is a problem, and just to make sure we can reduce some of the harms at an early stage. Parents, of course, also play an important role. So we also meet parents in the schools, for example, with school meetings, but we also do the specific talks with parents and their kids if necessary. So we also educate parents about drug use and screen time and gambling and all these issues. So then, so basically, who are we targeting? Well, the general audience, youth, adults, but also the loved ones, the people around somebody that has that uses problematically or has an addiction. And we could also target specific groups that are at risk or are around people at risk, so the professionals, but also, for example, people that like to party and people that practice chemsex, for example. Chemsex is like a term that signifies that people use drugs combined with sex, and then specifically they use the drugs to make the sex more intense. And that's often happening the case with men having sex with men, but it could also happen with any sexual orientation. It doesn't have to only happen with men having sex with men. So that's, of course, a group that's also at risk. If you look at the use of drugs, you could look at different stages of drug use. People are often, of course, introduced to drug use the first time they encounter a drug. They might use it once, they might experiment a few times with it, and then they might continue using it recreationally or socially. They might, for example, drink a few alcoholic drinks at birthdays, maybe every couple of weeks, but not too often. They might take ecstasy or amphetamines or other stimulants maybe twice a year, just to have a bit of fun, but that is not necessarily problematic. That use could turn into habitual use or functional use where it starts to have a function, for example, to reduce anxiety. And then already you see people starting to have some issues at some point in life. For example, it could be finances, it could be socially, it could be with school or with work, or it could be with physically. So you see some problems starting to emerge. Then people could transgress to problematic use or excessive use, where you see definitely more problems popping up in any of these areas that I mentioned before. And then people could become addicted. Well, often we say all use is a risk. Of course, that's true, but it also means that there's less room for nuance. Of course, if people use twice a year, the risks is still real because they could take a dose that's too high and die in the worst case scenario. But the risks are definitely lower than if people use daily or even often and problematically, or they have an addiction. So we try to also put that nuance back in the risk of drug use. So we say, of course, drug use is risky, but it's not always dangerous. So we try to bring a nuance in that discussion. Next slide, please. So for the general audience, what do? We have preventive consultations, so people can come to us and have a discussion or a conversation about their drug use. So we try to figure out what's the situation, what does the person want, how do they get there, but also it could be for the user, but also for the surrounding, so the loved ones, for example. And with a preventive consultation, that sounds already a bit like treatment, but it's at a way earlier stage. So people might have just an issue with their use, but it's not problematic yet. But this is a way just to open up the conversation about use and possibly problematic use later at later stages. So this is also just a way to open the door in case things get worse at a later stage, that people feel like, oh, the Jellinek is a partner that I can talk to. It's just normal people. They won't judge my use, but it's just a way to open up, like, hey, we are approachable. If you get into problems at a later stage, you are still welcome. We won't judge you. So we find that that's actually quite important, to just be open to people and show that we are actually there to help. Also for people in the surroundings of people with an addiction, it's important to feel that they are not alone, that they can actually also, there's help for them. So for them, it's also important to find a place where they can open up. Then we can also do consultation and advice. So that's basically for professionals, but it's a similar kind of simple conversation. It's not very into depth, but it's just a 1 or 2 time conversation where we can have sit next to them and see what their situation is like. They might have a patient or a client that is using problematically, and then we can see what we can help them with, what they can do best in that situation. Now, for example, we have some 15, 16, 17-year-olds that are using illegal vapes. So they use vaporizers, and often they contain also THC, so a cannabis-like substance. And they don't really know what to do with it. So we can have a short conversation like, okay, how do you approach that person? What can you do for them in that situation? We also have screeners online, so people can actually see how risky their use is. Often people don't really know at what stage they are, so sometimes they feel like, I want to see if I'm using drugs in a risky way, or if it's still okay. So this is also a low threshold way for them to see if they possibly need help, at what states they are, and if they want help, where they can get it. Then, as like a step up from the consultations that we do, we have two MOTIs, like motivational conversations, MOTI 44 or MOTI 55. So that's basically 4 consultations to gain insight a bit more into behavior. So that is starting to look at like a treatment, but the problems that people have are not as severe. So it's still, yeah, problems are easy. So you don't really need like a psychotherapist or a therapist, but somebody that can help you get some insight into your behavior. So we look at the balances of the benefits and the cons of certain behavior, which could be like drug taking or gambling or screen time, for example, and also what is behind the behavior. Well, our alternative behaviors, for example, if you are experiencing anxiety in social situations and you tend to drink, what else can you do to lower the anxiety? And also, is there a network that can possibly help? Or you have friends or family or a spouse that can help in that case to lower the anxiety or lower the behavior that you don't want to show. If people want some help, but yeah, they find it, they want to prefer to be anonymous, and the problems are not very serious yet, we also have a self-help online. We have it for alcohol, tobacco, cocaine, cannabis, and gambling. So people can just enter. They just need an email. So it's anonymous. It's at their own time, whenever they want to do it. This is online self-help to also make them get a bit of insight into their behavior and to get some tips and tricks on how to improve their behavior and therefore their life. And if we find that they need more help, then of course they can get some treatment. Next slide, please. So in general, we have a website with a lot of information. And often, if there's something happening in the media, we will automatically put it on our website so people can actually find our website and to find proper information, because on social media there's often a lot of information that might be wrong or miss a nuance or in any other way is faulty. So we prefer to put it online as quick as possible with the correct information. We also have a phone line. So if people have questions, could be professionals, could be users, could be the next of kin, anybody else that has a question, they can give us a call or they can chat online. Just then both of them are also anonymous. Then we have a middle meter, so like a drug meter is an app to keep track of your drug use that you can help to figure out how much you're actually using, because often people find it difficult to keep track of how much they are using. So this app can help. And of course, there is many of the anonymous organizations that can help. We facilitate the meetings. So it's Alcoholic Anonymous, Narcotics Anonymous, Sex Anonymous, Gambling Anonymous, Overeater Anonymous, and several others. For example, also like people that weren't using their phone too often. So Screen Time Anonymous, but they don't have a name for it yet, I guess. But yeah, there's many different groups that can help, and they have meetings very often. And it's very low threshold. So people can announce that they're coming, but they don't have to. They can just show up, and then they can have conversations with peers. So other people that are using, that stopped using. So they can give each other tips and support on how to go about your drug use, how to stay clean, how to yeah, how to stop the addiction. So this is also an option that we can provide if people have to wait for treatment because we have often, well, sometimes a pretty big gap between actual, um, um, yeah, that they say, well, I need treatment, and the time that they actually get the treatment because there's a waiting list. So then these anonymous groups really help a lot. So they're very helpful. Next slide, please. So for you, the youth, we have different options. We have consultations at schools that have a specific risk factor. Not all schools have kids that use drugs. So we try to focus on the schools that have a risk factor. So schools where there's a lot of kids that use drugs. Well, not a lot, but relatively more than at other schools. Also because we don't have the finances to go to all schools. We would, of course, like to, but we can't. So we have to make choices. And these consultations are not as a punishment for people that use drugs, but mostly as a support. So we also prefer not to talk to schools or classes in general, because most kids, they don't use drugs. So we don't want to inform them about or make them interested in drugs in any way. Because I remember when I went to school, we got a class, a themed class about drugs, and a lot of the kids were only like, "Oh, that's interesting. That's interesting." So we don't want to remind them that there is drugs that they can use. So we choose to only have consultations with the kids that are at risk or the kids that already use drugs, and then have conversations with them about their behavior and about their drug use. So it's preventative. We can also have these conversations with kids and parents at the same time. And it's not at the schools, but at our office. So we first have a conversation with the kids and the parents together, and then separately, because they both might have a different story. And it's good to have conversations separately, and then later we can join them again and see if they've gained enough information, and if we have if it was possible to help them. And often these are just a few conversations are already enough to help them on the way. So that's usually quite useful. The Motiv4, I already explained, is for short conversations to help people. What we also do is to train teachers, because often teachers don't really know which signs to look out for when kids are using drugs. So we train them in signs that could show people kids are using drugs. And what does it mean if they are using drugs? It's not always problematic. But so giving them information is very helpful as well. We can help them with the policy at schools. We can give themed lessons if necessary. And then we prefer to talk about alcohol, tobacco, vapes, and cannabis, for example. So these are drugs that are more likely to be used by youth, and not the more exotic ones like cocaine, ecstasy, for example, because most people, and especially not most kids, will never use them in their life. Then we have a project called, they translated to Clear at School. It's basically a system of different approaches to different kinds of ages. So for every age, there's a different approach that is, has roots in science, roots in evidence and research. It's not just, we're not doing just something randomly, but we're trying to make it evidence-based. And every age has a different approach, because every age needs a different approach, because they're dealing with different problems, different drugs. So it doesn't help to target them all at once. And then we have, which I also find personally quite interesting, different groups for children that have parents with mental issues or addiction. So one of them, for example, is called Beep, because Beep is what the noise of a mouse, and the mouse is an object that we use to have discussions about drug use, for example, of their parents or the mental issues of their parents. So these kids are often very young. They can be 4 years old, 6 year old. And through the little toy mouse that we have, we teach them to talk about their emotions, to talk about the issues, the situations that they have at home. So it's a very low threshold way to talk about issues that they encounter, because we know from research that a lot of the kids with parents that have mental issues, they will also later in life develop mental issues. So we will be able to help them, hopefully, to prevent these problems later in life. Next slide, please. So then for the youth, we also have peer projects. For example, a peer is like an equal. So it's your friends, your classmates that could tell you something about drug use, for example, because we know from research that peers are a more likely source of information and a more trustworthy source of information than teachers, for example, or parents or other people that have a different age that are not similar in lifestyle. So yeah, peers are important. So Connect is one peer project, for example, that we have. So it's for age groups from like 16 till 23, where they will go to schools and they have like a theater or a storytelling approach where they don't just give information, but they make it also more like infotainment. So it's entertainment, but it's also informational. So for example, it could be a theater piece about vaping or about smoking cannabis or about a classmate that is smoking cannabis and offering you to smoke as well. How do you deal with the peer pressure, these kinds of issues? Then we have also consultations at hospitals, the emergency rooms at hospitals. So in case of a young person entering the ER of a hospital with, for example, alcohol poisoning, then we can have conversations with them. Often the relationship with the parents we find is not very suitable or is troubling. So we look at the relationship with the parents, but we also give them psycho education on drugs in general, alcohol in general, but also we educate the parents. So it's not just the patient in this case, but also the system around it, because we find that that's important to prevent more incidents at a later stage. For youngsters, we find that there's also often problems with the parents. They might be very judgy, or they might really target the behavior, the drug use, instead of the actual problems behind it. So we also educate the parents, and we can have conversations with them. But it's also important to focus on the entire family. Sometimes just one family member is problematic, using problematically. So then the entire family is basically focused on that person, but they're forgetting about the rest of the family. So we can also help them to re-establish a correct focus on all the family members instead of just the one that is using problematically. So the parents are also a target group. So we have other peer projects also for adults. So for example, krachtkenners, which is like know your strength. So it's peers that are helping each other and their surroundings for mental issues and addiction. So people can join that group, and they can have peers that are helping them also with very simple daily situations. So it doesn't always have to be the use itself, but they can also, for example, with financial issues and other problems that they are encountering. Then I'll keep it short. We have LOS, which is basically a peer project for students talking about drugs and sex. We also have projects for people that are allowed, like foreigners that are allowed to stay inside the Netherlands. They ask for asylum seekers, so they ask for a permit and they're allowed to stay. And often we also see that they have very serious issues, mental problems, drug-related problems. So we have a project that can help them, and that's also basically often just informing them is the first easy step that we can do. So we also have some videos in Ukrainian. So they are based on the website. So if you follow the link, you can see them. Then the next, the loved ones, so the people surrounding the person that has an issue with drugs. These are often, we see a lot of issues with them. They might also get depressed. They might be anxious. They might, they might have too much stress. So they also need some help. So we also have consultations with them one-on-one, but we also have group discussions and group meetings, informing them about addiction and about drugs, and is basically focused on helping themselves, not necessarily the loved ones, because they often don't have much control over the loved one, but they can help themselves to reduce stress and take care of themselves. And next slide, please. So then the last bit is for people that are partying. We have a peer project called Unity, where we try to educate people that are going to parties about safer drug use. So we don't will condone the drug use, but we will also not say you should stop using drugs because people have already made the choice to use that drug. So we rather educate them and talk about them about safer use. We also have a drug checking service, which is basically a monitor for illegal drugs. So if people have decided to use drugs, they bought the drugs, but they want to know what is inside them, then we have a service for them all around the Netherlands where we can test their drugs to make sure that it doesn't contain anything more dangerous than the drugs themselves. And in case there is something dangerous inside, then we can do a national warning campaign if necessary. So that's a pretty elaborate system that is sometimes difficult to explain in a few sentences, but I have tried. Then we have a first aid for drug-related incidents for professionals. So for example, if people work in clubs or at parties, then we can also educate them on drugs in general, but also how to deal with if they have an incident that is drug related. So they get a bit more information on how to deal with these drug related issues. And then the last, we have webinars, also just to make it easy for people to learn. So this is a good example of, we're trying to explain what the Jellinek does to you, but we can also do that for many different other audiences. Could be parents, could be teachers, could be people in general. So we do quite a lot of webinars, we do trainings, and we have quite a few e-learnings on the website that people can follow them themselves and professionals as well. So that's very quickly what we do with prevention, but basically it boils down to avoiding for people to move up the ladder of the steps of the stages of use. We prefer to keep them in a recreational use or no use at all, and to help them stay in those stages instead of evolving to addiction. So thank you for your attention. And if there are any questions left from me and Keenan, we would love to answer them.
Дякую дуже за презентацію, шановні учасники.
Thank you so much for the presentation. Dear participants, if you have any questions, feel free to raise your virtual hand and try and ask the questions. Also, I'd like to tell you that we have 15 additional minutes to answer all your questions. There is a question for now to the previous session. I would like to read it. Could you please tell us if I got it right that if there is trauma and increased stress, gym and powerlifting brings even more adrenaline and stress?
I'm sorry, I don't think I completely got the question. Could you maybe repeat it?
Так, чи правильно, що
Sure.
при травмі та
Is it the right
стресі
statement that when there is trauma and increased stress, gym and powerlifting bring even more stress and lead to a raised adrenaline level?
Yeah. So if you're referring to like that previous question we talked about from the audience, I don't think it's possible to say that in a very sort of general way that is always the case. We do know that when for many people who experience trauma-related disorders, there's like a constant higher level of stress or stress hormones like cortisol in the system. And actually exercise can have a very beneficial effect on that. But in the example that was given earlier about the powerlifting, it sounds like there might also be an underlying reason for why someone is really associating these types of behaviors with stress. And without knowing the full story, because the person mentioned something about perfectionism and very high standards, it could be that is part of what's causing the stress, is actually constantly feeling like you're not doing enough, which can be related to trauma. But as you can tell, it's complicated. I don't think we can say in a sort of general way that this is always the case. For many people, exercise is actually a very good and healthy way to get rid of stress.
Дякуємо дуже за відповідь. Ніна, бачу вашу
Thank you
руку.
for your answer, Nina. We can see your raised hand. The floor is yours.
Доброго дня.
Hello, everyone. I want to thank for this useful and interesting information. I have a different question. Is there a chance for Ukrainians who are in your country to get the treatment in Jellinek, and how to do that? Thank you.
Yeah, maybe I should also take that one. Yes, actually, since the start of this year, we actually have a group treatment specifically for displaced people from Ukraine also suffering from substance use disorders. I have a colleague, Arkady, who is originally from Ukraine. So they are also able to do the treatment in their own language, which of course is very important, right? If you want to really express yourself, you want to be able to do that in your native language. So yeah, that is now possible, but of course, what makes it difficult is sometimes with such trauma that people have experienced being in a foreign country, and the stress that gives, maybe people need a bit more than just one group session every week. But still, yes, the option is there, and I think that it is even financed partially by the government because we really want to facilitate refugees, people that come here, and make sure they get the right support. But it's in group sessions. Yeah.
Дякую.
Я зрозуміла.
Thank you.
Дякую.
Thank you.
Маємо також питання
We
в
also
чаті
have a
щодо
question in the
джерел
chat
фінансування
about funding
діяльності,
sources
яким
for the
чином
activity
скеровуються
and how
потенційні клієнти,
the
пацієнти.
clients are referred to you.
Shall I answer that?
Mhm.
We have different sources of finances. So you can correct me if I'm wrong, but for treatment, it is all financed by the insurance companies. So people have health insurance. It's compulsory in the Netherlands, and then the insurance pays for the treatment. For the prevention work that we do, it is paid for by the local government. So, for example, by Amsterdam or Utrecht or any other city that we are working in. So we get money to do all the prevention programs that we are running. And every year we have to negotiate with them what they prefer. And for example, different targets group could change because society changes. So yeah, we get money from the local government and sometimes different other research projects, but that's smaller amounts. Referrals usually go through the general practitioner. So if people want to be insured and have treatment, then they can go to their general doctor. They can get a reference to us, and then we can help them. For prevention, it's often that we contact schools or people. So the schools we have close contact with, but for example, the loved ones, they often look online and they can easily find us. So yeah, it depends on the area that or of help that they need, but so it differs.
Дякуємо дуже. І також маємо ще одне
Thank
питання
you.
в
And we
чаті.
have one more question in the
Розкажіть,
chat.
будь ласка, як
Could you
можна
please tell us
доєднатися до
how we can
навчання до
join
вас?
the training
Можливо, подивитись
that you
ще
provide?
інші
Maybe
вебінари,
watch some
можливо,
other
є сторінка в
webinars.
YouTube чи
Maybe
на
you have
сайті.
a YouTube page or the website.
Yes, it depends because most of the things we do are in Dutch, and they are often also in classrooms or they're one-on-one. So we could have a look at some of the webinars if they are public, and if, for example, YouTube automatically translates them. So we will have a look at it. We might be able to send it after the webinar to see what's possible, but often they will be in Dutch, unfortunately, I think.
Чудово, дякую. І ще фінальне питання.
Great, thank you. And the final question about the term safe use to gradually decrease the use and get to remission. Did I rightly understand the term safe use?
Well, yeah, safe use could mean different things. It could mean that people stop using altogether, but it could also use that they use lower doses. So, for example, with party drugs, people often party for a long time, and they might take higher doses, or they might take combinations of drugs. So then we can have a conversation about that. And in that case, safer use might mean that they use less different drugs together, or that they use less of a substance. It doesn't automatically mean that they have to stop all use, but dosage and combined use are often topics in safer use because if the boring answer, drug use is never safe, but there are doses that are relatively safe. So you could take a certain dose and the chance of having an incident or negative side effects could be a lot lower than if you take a higher dose.
Дякую дуже за відповідь.
Thank you so much for your answer. Any other questions? Mariana? I have a question. Do you have the state program of assisted therapy, like methadone assisted therapy or something like that? Or do you believe that it's effective, or any other assistive therapies? The second question, what attitude do you have to coercive treatment?
Do you want to take that one, Raoul, about methadone?
I don't know that much about it. Maybe you have an answer?
Yeah. Well, I mean, what I can say, but the Netherlands has been pretty progressive with, for example, methadone sister treatment, I think already since the 1980s, where in a lot of different countries, people were quite skeptical about giving drug users more drugs. And when you say it like that, it sounds like contradictory. But we do know from having done those types of more harm reduction type treatments that they are generally more effective than criminalizing or punishing people. It's kind of good to actually realize that in a lot of countries in the world, still drug users, especially if it's in the public space, are still criminalized and punished, either because it's too visible, or maybe they're causing disruptions because they're maybe confused or intoxicated. But there, especially during the 1990s, there was a heroin epidemic in Amsterdam that was, and other cities in the country, that was very effectively treated actually with methadone assistant programs. And to this day, it still exists, but I think the Netherlands has been one of the countries where it has been the most successfully treated, and we actually have very few opioid related problems here in the country compared to Eastern Europe, for example. So yeah, I think that's something I can say about it. And what was the second part of the question again?
Coercive treatment, forceful treatment. In what cases do you use coercion in our country, in your country, and in your opinion, is it effective?
Yeah. So I can say a bit about how it works in our country. And of course, like coercive treatment or forced treatment is really always a last resort. And it can be done in the case of, well, what you'll generally hear is if someone is really a danger to themselves or other people and is not voluntarily committing to treatment. It could be, for example, that someone is like completely deteriorating in their health, like if someone is in their own home and, for example, delirious from alcohol use or is about to die, but is not accepting treatment, and is maybe also aggressive towards the neighbors, just to name an example. Sometimes in those cases, there can be coercive care. If someone has a psychiatric episode, for example, someone becomes highly suicidal or psychotic and is showing dangerous behavior, then in those cases, sometimes people are taken into care against their will. But it all has to be done, of course, according to very strict procedures where a government, like local government, has to approve that this is done, because it's really, it can be very traumatic for people, and it's really the last thing you want. Caregivers also really don't like doing that, right? Taking people against their will. And when it comes specifically to addiction treatment, I don't know exactly for sure, but sometimes people with more forensic psychiatric problems, so they are, for example, very aggressive or show like very violent criminal behavior, and there's also substance use. I think sometimes as part of their criminal sentence, it can be one of the conditions that they also need to take addiction treatment as part of it. But yeah, as you can imagine, like it's really important for the success of the treatment that it's voluntary for the most part. But sometimes you really have no choice. Yeah.
Дякую дуже.
Thank you very much. I suggest that we conclude our meeting because our time is up. Thank you very much, Raul and Kiran, for your presentations. Our participants do appreciate your work, presentations, useful and beneficial information. They are grateful for being open and sharing your information and supporting our country. Thank you very much. Have a great day and a peaceful day, and we will share all the materials after the webinar.
Yeah, and thank you very much for having us and for your attention. It was yeah, also quite special for us to be able to do this together. So yeah, thank you very much.
Yeah, I agree. Thank you all very much, and enjoy your day.
Thank you.
Yes. Okay. Thank you. Bye-bye.
Thank you.